So my name is Brad, getting ready to graduate from the nursing anesthesia program. Glad to be with you today. So we're doing basic anatomy and physiology. As I said to some of you earlier, this is a slide I pulled off, I think the testing site from that you guys will be using. So these are the goals of, I guess, this presentation. We'll identify normal physiologic lab values. There's not too many lab values with anatomy and physiology, but we'll look at that. Administration of anesthesia. So the basic anatomy, musculoskeletal system, nervous system, respiratory system, vascular system, including CV. The majority of the information we'll be covering will kind of focus on the heart and the lungs. So two of the biggest areas in the book, two of the biggest areas that I've ever been tested on. So it does say there'll be 7 questions from this content. So just keep that in mind when you're kind of hearing all these presentations, where that fits into where you should spend your time. I think 7 questions is probably middle of the road for the different sections you'll be hearing today. So, this is the absolute truth. Keep calm, call an anesthesia tech. You guys are wonderful to us. Starting out, I know probably the biggest asset to a new nurse anesthetist is having an anesthesia tech. So we're glad to do this for you. Wish you the best of luck studying with all this. So getting right into it, we're going to have a lot of pictures here, especially the anatomy portion of things. I mean, you can't really substitute it, can't really talk about it, so there's a lot of words. We'll kind of hit through some of these slides that I think aren't as important and kind of tell you where you need to be spending your time. Feel free to interrupt me, stop me, say, hey Brad, go into more detail, or I already know all this, keep going. Okay? So, obviously your heart's located in the middle of your chest. You'll hear the word mediastinum to be that area. That's the area between your lungs and the pleural coverings. So one of the confusing things when they talk just some of the anatomy questions, they'll say base. And you think of the base as the lower part, but really the base of your heart. If you think about it in your chest, kind of looks like your fist with a smaller portion pointing down. That's actually the apex, and the top is your base. So don't confuse there. It's covered in a thick pericardial sac. That sac, I don't think you need to know the 30 to 50 cc's of fluid, but that fluid is there to kind of, cushion your heart when it's moving around and things like that. If there is extra blood in that area, say there's a bleed from your heart, that's when you can get tamponade, life-threatening conditions that do pericardial stenosis. I'll try to say things that will refresh us to what we actually deal with in the clinical arena. Okay. So here's a picture of your heart. Looking at it here, your major vessels. And I have another slide that kind of goes into better detail, but the blood, deoxygenated blood, is obviously represented in blue. So it's coming back into the heart from mainly your superior and your inferior vena cava. Okay, those are the big vessels coming from everything north of your heart, your head. It's coming down through the superior vena cava. Everything from your legs, come back from the inferior vena cava down there at the bottom there. Going into, you have 4 atriums of your heart, your right atrium, or you have 4 sectors, let's say. Your right atrium, right ventricles, left atrium, left ventricles. Blood flows that way here. Let's go to a better picture. So you can see the flow of blood. This slide I would spend time with. Many questions I saw trying to cheat and see what other people have been studying kind of focused on the flow of blood through the heart. Knowing where it becomes oxygenated and when it's deoxygenated. And knowing when you go from your right atrium into your right ventricle, you're going through a valve, specifically the tricuspid valve. So I would know this one cold. This is kind of the big one there. Yeah, that's kind of self-explanatory. I can go through and tell you all the big ones, but I wouldn't worry about, actually, everything on this one I would know. So it goes, I'll trace it through just once for you. So it goes from the superior and inferior vena cava into the right atrium. It's going to go through your tricuspid valve. You'll hear the tricuspid and the mitral valves sometimes in the text referred to as semilunar valves. And then it goes into the right ventricle, into the pulmonary artery. That's another thing that can get confusing. Usually veins are deoxygenated blood, and then arteries are oxygenated. Well, it's a little different with the pulmonary system. The pulmonary arteries, it's deoxygenated blood. Okay, so it hasn't picked it up into the lungs yet. It goes from right ventricles into the pulmonary arteries, into the lungs. It's oxygenated there. Everything past that point will be oxygenated. It turns to red. So it goes from your lungs back through the pulmonary veins into your left atrium. It's going to go through your bicuspid or mitral valve into your left ventricle. That pumps, goes out into the rest of the body through your aortic arch. Okay? So again, this is an important one. Start this one. This is just another look at it. If you look on the right side of the screen, that's just kind of like a word version, so you don't get confused in all the flows there. But just another way to look at these things. Okay. All right. So that's the blood system flow of the heart, and the anatomy that goes along with that. Then you have the electrical part of your heart, so your cardiac conduction system. When you look at the cellular level, it's a little bit different between, there's 3 different types of cells. Specifically, cardiac cells are special because they can generate their own action potential or pulse. And that's how your heart beats by itself. We'll talk about a little bit of detail there. But all your cardiac muscles can generate that pulse. They can generate at different rates. And we'll see that your SA node, that is the pacemaker that you'll do here. That's most of us sitting around here, that's what's causing our heart to beat. Okay, that's the one that beats 60 to 85 typically at rest, generates that automaticity. When you see people getting into problems with rhythm disturbances, there's a problem in their conduction system. If they get into a point where their SA node stops working, and then there's other parts of your heart that can generate the pulse, the AV node will take over. I'll have a picture of that here in a minute. If that fails, then your ventricles are doing the pulse, and that's where you see here it has lower frequency, 30 to 40 beats per minute, and that's when the body starts getting into trouble. The entire conduction system is composed of, I'll have a picture here, SA node, Bachmann bundle, AV node, bundle of His, and Purkinje fibers. That's how everything works. And I'll show you a picture of that in a minute. We'll trace it through. And just know, I don't think this bottom part is important, but there's other ways if your heart, other conditions like Parkinson's, White's, and they mentioned in the book, have accessory pathways. So if you look at the top of this picture, really high up in your right atrium, there's that SA node, like I talked about, that's your pacemaker. When it generates an action potential or it generates an electrical impulse, those two words are the same thing, it goes down to your AV node, but it also goes to the left atrium. That pathway from your SA node to the left atrium, that's known as Bachmann's bundle. So the electrical energy or impulse goes down to your AV node, and it's worth mentioning here that there's between the atriums and the ventricles, electrically, they're kind of insulated from each other. So the only way that electrical energy can get there is through your AV node and the bundle of His. Okay, that's important when you have blockages there from electrical impulse. That's how people have rhythm disturbances and arrhythmias. So it goes down there, and then it equally goes through your right and left bundle branches, and you'll see if you ever hear a right bundle branch block, that means that part of the conduction system's not working. That energy isn't being transmitted there, so that part of the heart's not beating. So again, this is another important one for test purposes. There's going to be a lot of terminology that you may say something along the lines of, what is the pacemaker of the heart? And your choices will be SA node, AV node, something like that. Or they may mention part of the conduction path. Where does it go next? The AV node is kind of what slows the impulse. So your atrium or your SA node will send that electrical impulse pretty quickly, and your AV node is the one that kind of directs how quickly it goes to the rest of your heart. And so that's, I know I've seen that in questions as well. The AV node is responsible for slowing the impulse. If it's too slow, you'll have first degree and second degree heart blocks and things like that. So some more terminology here. This is going to be talking about coronary circulation. So on that first slide here, we talked about how blood flows through the body, but this doesn't really tell you how the heart gets its own blood supply. So the right and left coronary arteries, they arise from the ascending aorta, just above the aortic valve. And the coronary arteries is what supplies the myocardium, which is the heart, with oxygenated blood. When you look at the coronary artery, this is good over the arteries of the heart itself. This will directly tie into EKG analysis and things like that. And myocardial infarctions, heart attacks, and things like that. And so let's see, the left coronary artery has two main branches. So your LAD is your left anterior descending, and then your left circumflex arteries. I have pictures of those here. So if you see, I guess from you guys, it would be on the right-hand side. Your left coronary artery. LAD is the one that goes all the way down. Your circumflex kind of goes to you guys the right and wraps around the backside of your heart there. And then the right coronary artery, and the left circumflex, they go in opposite directions on the AV groove. So they're providing circulation to the backside of your heart, essentially. I include this part down here because I saw another question, and this talks about left and right coronary dominance. If you look at this, the last bullet point down there. So your posterior descending artery is different for everyone. Some people it's going to be supplied by your right coronary artery, some part it's your left. I don't know if that's important, but they had a terminology in the book they called the crux of the heart. So I thought I'd just throw that in there. If you're talking about the crux of the heart, it's at the point at the back where deciding who's going to be, whether your right coronary artery or your left circumflex artery is giving blood to the backside of the heart. So I wouldn't make a big point of memorizing everything on this. Diagonal branch, left marginal branch, all those things. Not that important, but from here I would know, you have a left coronary artery and a right, and that your left splits into the circumflex and LAD, left anterior descending, and then your right is just really your right coronary artery. Okay. Venous system of the heart, not that important. The only questions I've seen from here is talking about the coronary sinus, and that's just where the blood from the heart flows to get back into circulation. So just know that there's a coronary sinus, and it goes into the IV. If any of you guys work in the heart tower or help out around there, you'll see that that coronary sinus, they have to cannulate it to kind of vent the heart itself. Cardiac physiology. We had a teacher in our class who probably could spend 20 hours talking about cardiac physiology in itself. We'll kind of hit the highlights here. So when I say action potentials, that's just electrical signals in the body. When we're putting leads on patients, we're measuring those electrical activities that is generated by the heart. A lead, when they hear that, it's not a singular thing. It's actually two different points. So if you have a lead, you have to have at least two different electrodes on there to generate a lead. And you can generate, you can have different views of your heart based on which lead you're looking at. The most common lead that we look at for arrhythmia purposes is lead 2, because that's basically looking at your SA node. So you're looking for lead 2, you're figuring out if the SA node is working by itself, if it's working appropriately. And so then you can, if it's not, it's the first lead to pick up an arrhythmia. The rest of the leads, all the V leads that we have on there, if someone's doing like a 5-lead EKG, is looking at the heart muscle itself. So lead 2 is the best one for arrhythmias, and a V lead is looking at whether the heart is getting perfusion, appropriate perfusion. So that's probably could possibly be a test question. I don't know if they'll go into details as far as like which leads associate which part of the heart. I know we were asked those questions, but again, if you wanted to look at it, that's kind of if you memorize everything here, you know every single part of the heart, and you can figure out if there's I don't know, ST elevation, you can know what part of the heart it is and things like that. I wouldn't anticipate they would ask that though. This is a cardiac action potential. Again, I think this is worth skipping over. This just talks about how these signals are generated at the cellular level. Basically, electrical signal is caused by influx of sodium ions into the membrane and things like that. I wouldn't spend the time on that. So this is your ECG waveform. You have P wave, you have a QRS complex, which is that big jotted line up in front, and then T wave. We look at these things, on a daily basis with every single patient. 99% of the time, everything checks out, but one of the intricacies is trying to, based on some of these changes, you can figure out what's going on with your patient. The big ones to point out would be, if you see the ST segment, if that segment is going up, like elevated, or it's depressed, going down, that's a sign of, could be a sign of myocardial infarction. Like your patient could be having an MI. Also, like you'll see, like you can figure out, some anomalies with patients' chemistries by looking at that. The most common one is a peak T wave, so a big T wave would show that you have a lot of potassium in there. So those are just some little things you can look at there. Here is a chart just talking about each one part of this QRS complex. Abnormal heart rhythms. I'm just going to hit the big ones. So AFib, a flutter, or any atrial tachycardia. They're all referred to as narrow complex tachycardias. The big thing with these is you don't have a P wave. So any fast rhythm disturbance where you can't make out a P wave is going to be an atrial tachycardia, or a narrow complex tachycardia, usually AFib. And what's happening, if you look at the heart, is your atriums are contracting very, very, very quickly. It's not giving your heart time to actually fill. So if the rate is really high, that's something we need to do something about, so they don't start suffering symptoms from it. We talked about the AV node and how it kind of regulates conduction velocity through there, and that's where you're going to start getting some major blocks. If you have a PR interval that's very long, that's first degree block. We talked about the right bundle branch block or left bundle branch block, and that's just not getting perfusion to some areas of your heart. Arrhythmias can also originate in the ventricles. Everyone's probably heard of VTAC or VFib, and again, that's going to be some of the more major things that we need to involve with, because your atrias are not doing anything, so your ventricles are the only thing that's working at that point in time. Kind of big concept that you should be aware of is your heart gets circulation during when the heart's not beating. So it's burning really quickly. Your heart's working really hard, which increases the amount of oxygen it's consuming, and it also doesn't allow it to refill and actually get more oxygen there. So everyone has beta blockers, and we know that to slow the heart rate down, and so your heart has time to fill, it's not working as hard, and things like that. So anytime you have like a VTAC, by itself wouldn't be that bad, except that it's A, your atrias aren't working, and B, your ventricles are going so fast that you're not getting any oxygenation to parts of your body. So life-threatening requires immediate treatment here. That's VFib. This is the most dangerous arrhythmia. Physiologically, it's similar to atrial fibrillation, except it's only your ventricles that are kind of quivering there. Completely disorganized fashion, and so this is when we're going to start shocking and CPR and things like that. Any questions on all this stuff that I've kind of rammed over so far? Okay. Moving on here. So what causes these arrhythmias? There's like 6 things in the book lists. Myocardial ischemia or infarction. So that's just when the myocardial cells are starved of oxygen. They don't function normally. You have pH or electrolyte imbalances, and again, both of these things will show up on the EKG. You have valvular disease, CHF, things like that can cause arrhythmias. I guess those are the main ones. Cardiac volumes, I wouldn't try to memorize these numbers, but kind of understanding the concepts of what these words mean will help you, could help you on a test question. So your end diastolic volume just has to do with when your heart has filled, how much is in there, in your left ventricle, essentially. And systolic volume is when that left ventricle squeezes and beats, that's how much remains in there. And you can, different, disorders and the diseases affecting your heart can affect those. Your stroke volume is the difference between the two. So with each beat, how much you're sending out into your circulation. An ejection fraction, there's how to quantify it, but you probably know that's a measure of how well your heart's working. So someone who has a depressed EF, 20%, someone with CHF chronic will have a lower ejection fraction than I do right now. Probably 60, 70%, something like cardiac output. This is another slide that I would know cold as far as the factors affecting cardiac output, because you can think about it. Let me go through it here. How you manipulate this, and this will make sense again when we start talking about some medicines, when you get your pharmacology, how you can manipulate these things here. So cardiac output is the volume of blood in the heart, or the volume of blood that the heart pumps, measured in liters per minute. And so there's your formula. Cardiac output equals your heart rate times your stroke volume. Cardiac output changes when you exercise, when there's a fever, if you cool the body, it all changes. And anything that's wrong with your heart, arrhythmias, ischemic heart disease, valvular heart disease, they make big differences in your heart, or your cardiac output. So when we manipulate your cardiac output, there's basically 4 things we can do. And everything we do is one of these 4 areas. So if someone has low blood pressure, like they're not getting enough cardiac output to the system, we could give them something medicine-wise that increases their heart rate. We could give them epinephrine, and that will do a couple of things. But one of the things we'll do is we'll raise your heart rate. You see, you can change the end-diastolic volume of the ventricle. That's called your preload. So the amount of fluid that's in that left ventricle. And you guys know we do this all the time. We give them fluid. So if you hang a bunch of fluid, it increases their preload. You can get their heart rate or get their blood pressure up that direction, increase their cardiac output. We can increase the force at which the ventricles contract. We can do that with some medicines. Or in the heart tower, they can put like a LVAD or something like that. It's gonna manually do it for them. So that's one thing they can do. Or we can increase the resistance against which the heart must eject blood. That's called your afterload. So when you think about this thing, especially afterload, I think of it like you got a hose and you have water coming out and you want to wash your car or squirt your kids or something like that. It's just dripping out. You put your finger over it and kind of increase, the resistance which that water comes out. It shoots extra far. We do that with like neosynephrine, phenylephrine is a drug we use all the time to help increase that afterload, and it helps increase your cardiac output. Look in the other direction. If someone gets septic, one of the main things that happens is vasodilates and increases all of the blood profoundly, and so your cardiac output goes down. Reflexes aren't that important to know necessarily. It's all the different ones. I highlighted a couple ones that do have direct application. The main one is you've heard vagal, and so there's different ways we see that in the operating room. It could be when they're inflating a pneumoperitoneum, inflating the belly. It could be even just starting an IV. Sometimes people vagal down. This is a direct reflex from the originating mainly from the vagus nerve. When we talk about your parasympathetic and autonomic nervous system, so we'll kind of get it tied in here as well. All right, so myocardial oxygen supply and demand. So we talked about the supplies with coronary arteries, and as well as collateral circulation. The demand is directly linked to your heart rate. We talked about that a little bit too. And basically, if supply doesn't equal your demand, you're going to get some form of ischemia. And so we can either increase the supply by giving them different medicines to help increase your blood pressure and increase perfusion, or you can reduce demand, which we do sometimes when we cool patients down. They need less oxygen that way. All right. I'm going to break out the book and run over those questions from this section, just so you can get an idea of what they'll kind of ask. And either answer out loud or answer to yourself, just to get an idea. Alright, so looking at cardiovascular anatomy and physiology here. Which of the following is true about how blood flows through the heart? Actually, do you guys want me to go through this or not? Do you guys have the questions?
Yeah.
Did you look at them ahead of time? Is there any questions on there that you had trouble with or want more questions answered on?
These are the ones we have to watch out that they are answered wrong. answers are incorrect on a couple of them.
Which ones were those?
On the one you copied, number one's wrong. Some of the books it's right, and some of the books are wrong.
Huh. Each of the following is true about how blood flows to the heart.
I think that's right. Right atrium to left atrium to pulmonary, then to right ventricle, left ventricle, right?
To the aorta, let's see.
Because it makes it goes like this.
Yeah, so that one actually, D is the answer. So going back.
Because it makes like a figure eight almost.
It's the right atrium.
To the right.
To the left atrium.
Yeah, it goes to the left.
And it goes through the pulmonary artery. So when it's on the right side of your heart, you have to go to your lungs to get oxygenated. So right atrium to left atrium to pulmonary artery. Comes back from the pulmonary arteries through the pulmonary veins to your left atrium, left veins, and then to your aorta. So that one is correct. Yeah. Would be D. Basically, from the right side of your heart, it goes into your lungs. And then from the left side of your heart, it goes to your aorta, to the rest of the body. And it's good that we're going over that. Any other ones that we went through there? So looking at them, first question deals with blood flow to the heart. Second one has to do with veins. So again, it's similar there. Third one is about the ventricles. Fourth one is about the conduction system. Again, we're going. Fifth one is coronary circulation. Cardiac action potentials, which has to do with the conduction system, EKGs. So that's where I spend my time. I mean, it would be blood flow through the heart, coronary circulation, the conduction system, and ECG things. And then a little bit about preload, afterload. That's where I'd spend my time on that chapter. Alright? Alright, let's go to...
Well, number 6, that one is incorrect because it says the answer is false, but the answer is true.
That's correct.
Number 6.
What does your number one in your book say?
It says B.
Mine says C.
So 6, the cardiac action potential represents the changes in membrane potential in myocardial muscle cells in the flow line. Yeah, that one is wrong.
Looking at 2 different editions of the book.
It's
Yeah,
the
really, it has
same
to be
edition. We actually called about some of the mistakes because we had a book over 2 years ago. But
You're right, 6 is true.
Yeah.
It's key wrong.
and they missed some of them, I guess.
What was the first one's answer?
It's D. We had to draw a diagram, so we could.
So it's right atrium to the left atrium?
Yes, yes.
Oh, it's the right atrium to left atrium. No, that is wrong. You're right. I didn't read that part. It's right atrium to left, right atrium to right ventricle.
Can we go back to that heart picture?
Yeah, definitely.
Wait a minute.
Man, that's pretty deep. I'm getting you a book that's not even. Alright, so. The actual answer.
The right atrium goes to the right
Ventricle.
ventricle,
right.
to the left atrium, to the left ventricle,
Right.
to
You're
the
right.
aorta.
It's C. Sorry.
So it is correct.
Okay.
Well, in my edition, it's wrong because my edition says answer is D.
Mine is too.
So yeah.
Okay, so which one are we deciding is correct?
If the question is which of the following is true about how blood flow flows through the heart, and your choices are so A, right atrium to right ventricle, which is correct,
Right.
but it does not go straight from the right ventricle to the left ventricle, so that one's wrong. B is right ventricle, that's already wrong because we know it starts in the right atrium. So C is the correct answer. Right atrium to right
Right
ventricle,
ventricle to the
to the pulmonary artery, which you see on there, to the left atrium, to the left ventricle. Yeah, that is you. Yeah.
It's C.
Yeah.
It's C.
So you were right.
Mine's C. Mine's correct. This is correct. I mean,
You have the correct one on that
This
one.
is correct.
This one is wrong, saying D.
It doesn't cross the heart. To this question.
Yeah. And
So it
then,
goes right atrium, right ventricle, pulmonary to left atrium, left ventricle, yeah.
and then in my copy, number 6 would be wrong too. It says answer is B, but then the description of it corrects it. That's weird. So I would use
Which
these
one?
questions, especially to show you
What
which
you're
areas to
talking
study.
about,
Oh.
true, false.
It says answer is B,
But
but then the
yeah.
explanation says true.
That's what mine.
Okay.
All right, so that's the heart. That's probably the biggest one I would spend time with. This is the second big one is here. Is the respiratory system. Yeah, like, unless you're a heart person, you don't like the heart.
Oh, look at number 13 before you move
Yeah.
on too, because that one may be wrong.
The key wrong as well.
Yeah.
13. Which of the following is not a determinant of myocardial
You
oxygen
have to really
supply?
think about that one.
Not a determinant of the keyword there probably is going to be supply. Alright, so hemoglobin level, afterload, blood oxygen saturation, coronary blood flow, and diastolic time. Yeah, that's a tricky question. Did you read the answer underneath it?
Yes.
So they're saying,
Well, it says which of the following is not a detriment, and it says afterload is a detriment.
It's oxygen demand.
yeah, that's
Supply.
the keyword there
It's
is going to be your
trick.
supply.
Yeah,
Okay.
it's a trick question.
Yeah. So
So
diastolic
it's
The
time.
reason I
correct.
know this, that's what I had a hard time with, and I have to ask him.
So when you're looking at this one here, so like diastolic time and coronary blood flow are both directly related to your heart rate.
Okay.
And so, the period of rest when blood's filling. So both of those are the same thing. Blood oxygen saturation has to, obviously the supply there. And your hemoglobin level is going to help determine the supply. That's a tricky one. We didn't touch too much on that.
Yeah, that's a really tricky question.
So respiratory system here. Started off here, when you take a deep breath, the first thing you do goes through your upper airway. It consists of your nose, your mouth, your pharynx, and your larynx. You can see those there. Just of note, basically when we're putting someone to sleep and we're intubating them, we're bypassing all of their defense mechanisms. So, all their receptors and your cilia and everything that goes on there. We basically pass all that there. Larynx is composed of muscle and cartilage, contains the epiglottis, your arytenoid cartilage, vocal cords, cricocartilage, hyoid, thyroid cartilage, and cricoid membrane. So that's everything there. Your vocal cords forms the glottic opening, as we're putting the ET through, E2 through. So here, I wanted to spend some time talking about this because I know we do cricoid pressure and things like that. So when you guys get trained, does someone actually show you how to do cricoid pressure and everything like that? We read about it and they were like, oh yeah, you should put pressure, but so in guys it's easy. If your thyroid cartilage is your Adam's apple, then below that you can feel your the little hole in between your cricoid cartilage, and then when you're actually putting pressure on the cricoid ring, it's the only continuous ring. Basically, our goal there is to just press it back. It is occluding your esophagus and prevents aspiration risk. Contraindications are going to be like if your patient starts throwing up, you want to let go of pressure because that would just cause more damage to them, things like that. Basically, that's what we do. Because despite amazing advances in science, your patient cannot breathe through, so that's kind of funny. That's what we do here. This is just details on putting cricoid pressure, and something I had learned afterwards is talking about this burp technique. Very similar to cricoid pressure, except especially if you're ever doing it for kids, this is very helpful there because their anatomy is a little bit different here. But burp stands for backwards, upper, rightward pressure. So instead of just pressing straight down, trying to include it, you're actually going to go down, up, and a little bit to the right. And that will actually help both with the view for your anesthesia personnel, as well as actually achieving what you're trying to do in a rapid sequence induction of a kid. It also can work in adults too. So if you're holding cardiac pressure and you see that your anesthesia personnel is struggling, if you could just go up and to the right a little bit, or you can kind of wiggle it. If they're looking at the esophagus, is not going to move, so it will help. But if they're looking at, if they don't really know if that's the right place and it starts moving when you do that, they'll know that, hey, that's what I should actually try to do. So you can always try that if they're having trouble there. So the lower airway is what you typically think of when you think of lungs. It includes your trachea, your bronchi, your bronchioles, alveoli, pulmonary arteries, and things like that. I have some questions on there that do talk about they may say like, is your larynx part of the upper or lower? Basically, is it upper or lower? So if you can kind of memorize like these things here as part of the upper, the other ones as part of the lower, that would probably help. So your lungs, you have the right and the left side. It's 5 lobes total. There's two on the left and 3 on the right. The somatic question, the lower airway is composed of tubes for airflow. So you have your conducting airways. That's basically how oxygen and air is getting to, it's like a hallway for it to be getting to your lungs, or the part that's actually going to be getting the oxygen into your bloodstream. So that's the conducting part. And then the respiratory airways is actually where gas exchange occurs. I've seen questions on that as well. Your trachea branches into 2 main stem bronchi there, and they come out at different angles. The right bronchus branches from the trachea at a less acute angle than the left, which is why when SRNAs are all jazzed up, but they finally intubate someone correctly and they shove it in there, it's probably going to go into the right main stem. There's less resistance there. Also, someone's going to aspirate. If you look at their X-ray when they develop a pneumonitis, it's going to be on the right side 9 times out of 10. That's just because path of least resistance. There's a picture. You can see where we put that cricoid pressure up there with the cricoid cartilage. Trachea comes down. You can see on there the carina is the point where it splits. Most of the all that other little stuff I wouldn't worry about learning because no one's ever learned that stuff. And it's Valentine's Day coming up, so I thought that was perfect. All right. Trachea, bronchi, bronchial, conducting airways. We talked about that. The alveolar stacks. They have very thin membranes. That's actually the functional unit where gas exchange is taking place. This down here at the bottom says the lungs do not collapse under normal circumstances because they're adherent to the interior chest wall by a layer of fluid in the space. This is like a subatmospheric pressure there. And then basically that last point kind of explains like if you get some sort of air in there or something like that, or a hole in there, why that lung is going to deflate. You're not going to have breath sounds on that side, basically. All right, so the volume of gas that is inspired each minute is called minute volume. So volume, when we're doing this next little part, is a quantity of gas that can be inspired or expired and is not divided into further smaller quantities. And then you'll hear things called capacities, and that's 2 or more volumes added together. If you see, it's kind of messy here, but the one thing, I don't know if they'll ask it, but that top chart is pretty standard where they can ask questions from. It involves kind of knowing like your tidal volume is kind of what, if you and me right now are just taking breaths, that's your tidal volume. If I asked you to take as deep breath as you possibly can right now, that extra, so like right now, you're breathing probably like 500 cc's, something like that. That extra air, that's going to be your inspiratory reserve volume. So that's the area that like you don't breathe like that normally, but you can. If I ask you to blow out as as much as you possibly could. Breathing normally. But then I go, that extra air there, that's your expiratory reserve volume. You can't breathe out all your air that's in your lungs. What's remaining is your residual volume. And so that's kind of explaining those terms. Then they have other terms where they kind of added those things together. Like you can see your forced vital capacity is your tidal volume plus your inspiratory reserve volume, things like that. Again, I would be familiar with some of that. I don't know if they'll ask you at that level of detail, but at least know what volume, a difference between volume and capacity is, and maybe some of those as well. So your lungs, they receive blood supply from two sources. First is your pulmonary arterial system. The second one is source of blood is the bronchial arteries that come right off the aorta. How your lung gets blood. I'm going to skip this here. This talks about, I should mention at least dead space ventilation. So this has to get into so for gas exchange to have you ever heard VQ mismatch or anything like that, or people saying like that? So it has to do with it's not a very hard thing to say. So ventilation is basically oxygen that you breathe in coming in contact with the blood. Okay, so that you're in your alveoli, those little sacs that we talked about, they have a very tight network of very small blood supplies that wrap around it. Oxygen goes in, it diffuses across that membrane, and gets into your bloodstream. Okay, so if you're say you're breathing it in, fine, but there's something that's blocking the blood from getting there. Okay, so you're having ventilation, but you're not having perfusion. And I'll have to make sure I read this. I put this on here because I always get these confused here. One of them is shunt. That's it. So shunt occurs when blood flow through the capillaries surrounding the alveoli. Okay, so that's shunt. These are terms you should know. Shunt is when blood flow is getting to your alveoli. So you have blood getting there, but no oxygen. You're not breathing properly. Okay? And then so a true shunt would be something like a mucus plug, or someone swallowed a quarter, so it's blocking oxygen from getting down into the blood. The blood's getting there fine, but there's just no oxygen. That's shunt. Dead space ventilation occurs when it's basically the opposite. So you're breathing fine, oxygen's getting into the alveoli, but something's preventing the blood from getting there. That could be like an embolus, or something like that. So those terms confuse everyone. A shunt is when you have perfusion but no ventilation, and then dead space is the opposite. Here's a picture. Not a very good picture, but again, it's saying perfusion without ventilation, shunt, ventilation without perfusion, dead space. Getting into, there's another little chapter that will talk about acid-base balance and pHs and things like that. The lungs help regulate pH through the connections with the brainstem. If the CO2 levels or the blood acidity increases, the brainstem increases minute ventilation in an attempt to restore the pH to the normal value. So that's just basically saying, if someone is, we do this all the time, if someone is narked out, we give them too much sedation, and they are not breathing enough, CO2 rises, CO2 has hydrogen ions that kind of get in there, and we adjust it, basically. Your body will try to attempt to restore itself. We have to do it for them when we give them anesthesia, so we'll breathe them faster to make the CO2 levels go down, or vice versa. Alright, so talking about monitors of breathing, obviously there's visual inspection. You can see the respiratory rate, you can see their chest rising and falling. We can see on their ECG forms, your ECG will actually have your respirations on there. That works from something called impedance plethysmography. We have stethoscopes we can use. We can look at their airway pressures and capnometry, which is a measurement of CO2. And that's going to be your gold standard. If they ask what a gold standard is for an intubation attempt or something like that, it's going to be sustained CO2 capnometry. Common anesthesia ventilation parameters that are monitored. I'm not going to read all of it. That's ridiculous, but high pressure alarms, low pressure alarms, peak inspiratory pressures, tidal volumes, respiratory rate, inspiratory and expiratory flows. Someone's going to be talking to you about the anesthesia machine. They will be covering this probably in better detail than this. And these are just your normal values. When we first started this, I said that there are some normal values at the testing site. These may be examples of things that you want to know. There's not tons of normal values that they give in the book, but they provided this table. So I would try to memorize this, or at least be familiar with it so you can ballpark it. Any questions right now, moving forward? Pharmacology. I know someone's going to be talking about pharmacology towards the end of this program or in training sessions, but we've been asked to kind of where it's appropriate, stick some pharmacology in every section. So when it talks about the respiratory system, there's a set number of drugs that we can give. And so sympathetic stimulation causes dilation of the bronchioles, while parasympathetic stimulation, which we'll talk about later, and that causes bronchoconstriction. And medications that cause direct bronchial smooth muscle relaxation are referred to as bronchodilators. So this is the most common thing you'll probably see us give. Include beta-adrenergic receptor agonists, that's like albuterol, and epinephrine, things like that. That's going to stimulate your sympathetic nervous system and cause, in the lungs at least, it's going to cause dilation there and help people breathe easier. You could have methylxanthines, so theophylline is the main one that people give, and then histamine receptor agonists, so Benadryl. Those are all different types of respiratory directed ones. The big ones I remember would be your beta-adrenergic receptor agonists, so albuterol, epinephrine, terpidolene, those are ones there. Medications that may cause bronchodilation indirectly, so this is like protropium. So it's basically blocking out the signals that would cause bronchoconstriction. So it accomplishes the same thing as the beta-adrenergic receptors like albuterol, but it does it a different way. They're longer acting as well. So people may be on these when they come to the OR, but we don't give them usually as a quick acting solution. And then there's just a note that medications, they may also cause bronchoconstriction. Obviously, we don't give those for that purpose, but if they're on a different drug, like a propranolol or something like that, those can cause a bronchoconstriction. And as well as anything that causes the release of histamines, like morphine, zinc can cause that as well, vancomycin. The takeaway points would be, I would know the albuterol, epinephrine, or the beta-adrenergic receptor agonists. There's also ways to change your pulmonary blood flow. So these are pulmonary vasodilators. Lots of different meds. So anything from the nitrate class, like nitroglycerin is a big one there. Calcium channel blockers, like cardipine is one that we give. Milrinone, the phosphodiesterase inhibitors, nitric oxide. I don't think these are as important because we don't do this as much, but in the heart tower you'll see a lot of these meds. And anytime someone has, MI symptoms, we give them something like this that would help. All right. So let's just talk about the anesthetic agents that we give and how they kind of affect pulmonary function. All of the volatile agents that we give, isoflurane, sevoflurane, they decrease the smooth muscle tone on the bronchi, the bronchioles, and cause bronchodilation there. Desflurane is the only one different, and that has a special effect. It's very irritating to the respiratory system tract. So if we're going to breathe someone down, do a slow induction like that, a straight volatile induction, we would never choose desflurane. I know that probably shows up in some questions there. Ketamine is an induction agent we can give. It causes bronchodilation, which is good, but it also increases secretions, which can be bad. Ketamine doesn't impair the respiratory reflexes, so if we were doing MAC anesthesia and wanted to keep someone breathing the whole time, we could bump them with ketamine instead of with propofol, which would knock out the drive. Propofol does cause bronchodilation as well, but it depresses their respiratory drive. So ketamine is unique in that it doesn't knock out your respiratory drive. Everything else does, but it also causes all that secretion issues. And then I would remember that DES, disorienting, is very irritating. Respiratory complications associated with anesthesia. So we talked about if stomach contents are aspirated, how the lungs may react to the aspirate, causing pneumonitis. Treatment: put the head of the bed down, you suction them. You can do a fiber optic bronchoscope to assess the damage. Atelectasis is when the alveoli, which is what we talked about, gas exchange occurs. It kind of collapses. Usually that's from if we underinflate the alveolar sacs, that we don't give them enough tidal volume. They can have atelectasis and have trouble breathing afterwards. So we give them big breaths after anesthesia to help pop open those little air sacs. Bronchospasm and laryngospasm, those are some of the bigger problems, especially when we're waking people up. Bronchospasm is basically when the circumferential muscles of the linings of the airways, they constrict. Treat that with inhaled and IV bronchodilators, so we give them some albuterol. We can give them some epi if it gets really bad, or even some corticosteroids. And then laryngospasm, that's when your cords slam shut. You can't get any air across. We can give them positive pressure. We can give them some acetylcholine, or with either one of those, if you can give them basically more anesthesia, which will help, one, get rid of some of that stimulation, two, cause that vasodilation in the lungs there. All right, that was a big one too. Any questions, comments? Let's look at it. Looking at the review questions there, did you have any questions over there on those ones? Is there anything keyed incorrectly or questionably? So the first question just talks about functions of the lung. Number two talks about, like I was talking about, the divisions, whether it's upper or lower. Upper airway on that one, has to do with filtering. Again, upper lower airway question, conducting airways versus main muscle. So I didn't cover that. Number 5, what is the main muscle of respiration? It is your diaphragm. Number 6. Any questions on any of these? Cool. All right, acid-base physiology. So acids are compounds that, when they dissolve in water, they donate a hydrogen ion. And bases are something when they dissolve in water will accept the hydrogen ion. So the flow of hydrogen determines whether it's an acid or a base. Let's see. So basically, if something's more acidic, your pH will go down. Normal pH is 7.35 and 7.45. So less than 7.35 will be an acid, greater than 7.45, or 7.4, I guess, would be a base. So physiologic consequences, why do we care about this? In the operating room, acidosis produces its most significant and obvious effects on the cardiovascular system. pH drops, so you get down to about 7.2. There's a noticeable reduction in heart muscle contractility, and if it gets down to 7.1, the entire cardiovascular system basically becomes much less responsive to catecholamines, which is like how we typically attack these lower blood pressures and things like that. So it makes it very difficult for us to treat hypertension. If you have people, running blood gases a lot of time, we're making sure this doesn't happen. If you ever have someone asking for vasopressin or something like that, it's because the ephedrine that they're giving isn't working because that acts on catecholamines, and the epinephrine that they're giving also works on catecholamines. So basically, if it gets that low, those medicines won't work. Vasopressin works on a different receptor, so that's why they're asking for that. Acidosis also causes hypotension due to peripheral arterial dilation. And acidosis also results in shifting potassium out of the cells. So, not good stuff. They talked about in here doing an Allen's test. So anytime someone does an arterial stick, we're supposed to do an Allen's test. That's when you kind of occlude the arteries of where you're working. This hand kind of doesn't get circulation for a while, and then you let up on the ulnar artery, which is by their pinky. And you want to make sure that's to see, and if it fills up and gets pink again, that means you have collateral circulation there. So we're sticking the radial artery, but we want to make sure that the ulnar artery works before we stick it. For the book purposes, I think that's what you're supposed to do. In real life, the validity of that, it's called into question, so a lot of people don't do it. But for book purposes, to ask you like steps, I guess performing analysis is appropriate there. All right, so ABG interpretation. I don't think we should go into a crazy amount of this. You can read about basically the big steps of how to do it. Basically, just look at the value. If it's lower, it's determining if it's metabolic acidosis, respiratory acidosis, and things like that. I just don't think they'll ask you those questions. If they do, this is kind of a big picture version of how to do it. You probably should know, like, not necessarily how to read one, but you should probably know the effects of acidosis and alkalosis and things like that. So respiratory acidosis is when ventilation is impaired. The lungs aren't able to breathe off of enough CO2. When you see CO2, especially when talking about the respiratory system, you should think hydrogen ions and acidosis. If you have a lot of CO2, that's acidosis. If you don't have a lot of CO2, the alkalosis there. So example of respiratory acidosis, so you can paint this picture, is people who have too much narcotics on board, or if you give them a high spinal, it's affecting how well they can breathe. COPD patients, they chronically have a lot of CO2, so they're chronically in respiratory acidosis. Or if there's something going on, like a high fever or something, they can't get rid of the CO2 going up. Alkalosis is someone who's having a panic attack, so they're every time you breathe out, you're breathing out CO2, so they're breathing out all their CO2, they don't have enough. Basically, you should correct the underlying cause for that. Looking at metabolic acidosis. So this doesn't have to do with the breathing part. This has to do with things that are going on internally. So besides the hydrogen ions that are generated from CO2, other metabolic processes, such as protein breakdown, is what generates acids. When the kidneys are unable to excrete the hydrogen ions, and you can get into like whether it's anion gap acidosis, or I'll give you an example for those. So there's two different kinds of metabolic acidosis. There's a normal anion gap metabolic acidosis. There's really only like one kind here, really, or like examples I could give. So when there's extensive amount of base that are lost, like someone has a lot of diarrhea, get rid of the base, so they're left with a bunch of hydrogen ions in their system. And so that's how you can get a metabolic acidosis there. The other one would be, so increase the anion gap, metabolic acidosis. So we see these a lot. This would be like someone had like lactic acidosis or diabetic ketoacidosis. So diabetic doesn't get their medicine. They have a bunch of buildup of ketones in their body, which are big proteins. So all that, when it's all said and done, they have a different kind of acidosis. You can't fix that with respiratory treatments and things like that. You have to fix the problem. That's all that they have on here. It's a very short chapter. You can read the questions that they have on there. Make sure there's nothing funky with those. There's only 3 questions. So if using pure HCl will have what effect on hydrogen? So if you're giving you exogenous hydrogens, you get more hydrogens. So more hydrogen is basically causing acidosis, and the pH will go down. So that should be increased. Before attempting an ABG measurement in the right radial artery, you notice the patient fails the Allen test. What should you do? And you can basically say that saying E, perform the Allen test. There we go. On the other hand, make sure you get collateral circulation. And then, yeah, I think all those are right. All right, central nervous system is the next one here. Not my favorite thing to talk about, so bear with me here. Your CNS can be divided into 2 distinct anatomical structures. Basically, you have your brain and you have your spinal cord. That makes up your central nervous system. A lot of this is going to be terminology. when you get to the different parts of the brains, there's a couple of different slides I'll point you to that I think every single test I've ever had has seen us ask these questions. So that's what you're down there. Structures that make up your brain. I'll have better pictures here in a minute. Cerebral hemispheres, your cerebral cortex, your brainstem, and your cerebellum. It's a picture of what it looks like, actually. So here's a good one to know. Cerebral hemispheres can be divided into 4 major areas, and they're responsible for different things. So frontal, the area there in orange, responsible for executive functions such as attention, conscious motor involvement, and behavior control. So with all this boring stuff, your frontal part of your brain may be having problems with your attention. Temporal, basically temporal equals auditory, so hearing, okay? Just link that in your head. Your temporal, that's hearing. Likewise, occipital is seeing or visual processing. Okay? Your parietal is a little bit funny, but responsible for understanding of symbolic languages or spatial relationships. There are other parts of your body or your brain that play a function there. Your basal ganglia, usually reporting to your thalamus, has to do with the large central structure in the cerebral hemisphere, acts as sensory integration points. So that's kind of like corresponding inputs, various sensory modalities, which basically it's like taking everything in and kind of managing it. Hypothalamus, below your thalamus, has a lot of important functions. Basically, it's connecting your central nervous system to the endocrine system.
Dr. Fertel, please
So, like,
call
when you talk about
7050.
your pituitary gland and hormones and things like that, your
Dr.
hypothalamus
Fertel,
plays a big role there.
7050.
Pituitary gland controls chemically mediated signaling, functions through growth, metabolism, blood pressure, sexual development. So pituitary glands, you get puberty, that's when that really kicks into high gear and starts working overtime. And then cerebellum, major functions to integrate tactile and proprioceptive sensory inputs and motor signals for the production of smooth motion and maintenance of balance. So you see that people with Parkinsonian responses, and they're kind of having problems with balance, and they're kind of spastic, they could have problems with their cerebellum. Brainstem is like the prehistoric part of your body here, your brain. It connects higher areas of the brain to the spinal cord. You'll see that in the picture here in a minute. The sensory and motor pathways from the body and sensory problems. Brainstem is further divided, midbrain, pons, medulla. Your medulla, that's like your unconscious actions here. Your medulla controls your vital signs, essentially your unconscious functions. It includes your breathing rate, your heart rate, basic things that you're not choosing to do. You can affect your breathing rate, but that's using a different part of your body. So your unconscious part is your medulla or your brainstem. So looking at it a different way, from the outside in, you can kind of separate the part of your brain, the outer layers, into your meninges. So there's 2 different layers. This gets into, I guess it comes into play on a variety of things, but so your dura mater is the most outer part of your brain. It's basically just a thick protective layer. It's contacting your skull. Arachnoid matter, and that's your fluid-filled cavity. There's a fluid for that cavity called your subarachnoid space right below it. That's going to contain your CSF. So that's the main thing there. Dura's protection, CSF is the arachnoid, and your pia matter is just a thin layer that runs along the surface of your brain. When you supply the brain with blood, it's coming from your vertebral arteries and the internal carotid arteries. Then it forms something called the circle of Willis, which is like a big stream of collateral circulation. If you're ever in the vascular room, it comes into play when they're clamping different internal arteries and things like that. It has to do, you'll see that we spend a lot of time with positioning of the neck, because if you occlude your vertebral arteries when they're clamping your internal carotid and things like that, doing like carotid cardirectomy there, if you occlude it like this, then they're not going to get any circulation to the brain. Patients can wake up with strokes, stroke-like symptoms, and things like that. So clinical applications. When you think of the head, it's a closed vault space. So anytime there's an increase in anything there, whether it's CSF or if there's bleed or there's a tumor, can increase your intracranial pressure. So ICP. And you can put pressure on your brain, causing injury. All of the inhaled gases we give cause dilation. So when you have dilation, you have more room for blood flow to go, I guess. And that can also increase your ICP. If you're doing neuro cases, or you're in the neuro room, sometimes they can measure the intracranial pressure. They can put a bolt in place, or basically anything else to measure the pressure there to make sure that we adequately treat, do something about if they're getting too much ICP. Things we can do, we can hyperventilate them, get them to breathe a bunch. That would lower your PCO2, which causes a cerebral vasoconstriction, which decreases the blood volume. Or you can give them medicines like osmotic diuretics, mannitol is the big one that they give there, or hypertonic saline. And that reduces the amount of edema fluid in the brain. So that's a little bit of pharmacology thrown in there as well. Anatomy of the spinal cord. Basically, the spinal cord goes to 4 sections. There's 33 total vertebrae. You have your cervical, thoracic, lumbar, sacral, and then your coccyx, which is used. The number besides how many vertebrae there are on each section. Each of the 4 regions of the spinal cord controls different things we'll talk about here in a minute. Your cervical spinal cord controls motion and sensation of the neck and upper extremities. Thoracic controls motion and sensation from your trunk. And your lumbar and sacral regions does your lower extremities there. And these are just kind of like miscellaneous facts. Within the spinal cord, there's gray and white matter. Gray matter is composed. How do you bother relating that? The blood supply from the spinal cord comes from the vertebral arteries again, and from little segments coming up your aorta called the medullary arteries. Patients are at great risk of experiencing critical reduction of blood flow and injury to the spinal cord during surgery that requires cross-clamping up to the thoracic aorta. So basically putting out blood supply, you're at risk for having symptoms there. So that's a lot. It's kind of boring here. Let's see, physiology. Again, this is like very going down to the cellular level. I would be very surprised if they ask details on this. But from a big picture view of this, you kind of should know in case they kind of ask about things. Major functional cell from the central nervous system is called the neuron. A unique characteristic of neurons, when you're looking at comparing them to other types of cells, is they have this long cellular projection called an axon. So basically on this picture here, the axons are those little things with tentacles coming out. Those are dendrites, and that's just point of connections there. The axon are these little blue things. They're called Schwann cells, and they're covered like in a very thick, kind of like insulation, and those are called myelin or myelin sheaths. And this is how basically signals are sent very fast. Is with if they're insulated, they go quicker than if they're not insulated. So if they have a myelin sheath, you know that it's going to be going quickly. And the axons allow for signals to be sent between cells. That's why we can do things very quickly. The functional connection between 2 neurons is called synapse. Just technical things here. When a nerve signal reaches the end of the presynaptic axon, it causes a release of chemicals called neurotransmitters from the axon terminal into the synaptic cleft. I have a picture of this and we'll talk it through. And that's a small space between basically where the message is coming from and where it's going. Let's see if I can find the picture first. Alright, so from here, that little pull-out version that they have that's a close-up, that's basically what's happened is electrical signals come down from, say, it's from that very top dendrite. It's going down along the axon through your myelin sheath, so it's going very quickly there. Once it reaches this next place, I think we get this with the autonomic nervous system, but I'll hit it here a little bit. That close-up there is what's happening at basically where the axon ends and that dendrite is happening. And a signal goes down. It is an electrical signal that causes a chemical change. And that chemical change is when you release these neurotransmitters. And that's like how everything works to send signals through the body. Alright, so going back to the parts of the brain here. There's two major areas that we should know for testing purposes. And it has to do with language. So within the cerebral cortex, the areas involved with language fall into the temporal and the frontal lobes, predominantly on the left side. Broca's center is that one that's labeled in blue. That's the motor control of speech. And then you'll see Wernicke's center, and that has to do with interpreting speech. Those things people love to test on. And so more details about it. Broca's area is in the left frontal lobe. It's anterior to the primary motor cortex, and it's involved with the efficient production of language and speech. Broca's area is important for the motor planning involved in speech and for fluid expression of language. So if you have damage to Broca's area here, you're going to get aphasia, which will present difficulty in language production. So, like say I get that part of my brain damaged, and you're talking to me, I'll know what you're saying, but I can't say anything back. I'll talk, and if you've seen someone have expressive aphasia, like they make sounds, they can't make the words happen. The other area is, as I said, Wernicke's area. It's region of the cortex in the left posterior temporal lobe, and that has to do with understanding of language. So if that area is damaged, you can talk fine, make your words sound right, but if you're talking to me, I don't know what you're saying. It's like you're speaking gibberish to me. Okay? So those are the two areas I would know what happens if it's damaged, and then I would also know where it is in the brain. So Broca's area is to be your left frontal lobe, and Wernicke is left posterior temporal lobe. Those are like special areas there. You hear limbic system, just think emotional response. It's just a part of the cortex that contains, affects the autonomic nervous system associated with emotional response. And then hippocampus, I kind of highlighted every time I hear hippocampus, I think of storage retrieval of memory. And then cerebellum has to do with muscle memory. So if you just know anything about those, just pair those two things together in your mind and you'll be alright. Just FYI, strong emotional states encourage memory encoding, and so emotionally charged events are remembered more accurately with more detail. It's funny, I listened to an interview today, and they're interviewing a coach, and they're like, or Magic Johnson, they're like, do you remember your wins or your losses? And he always remembers his losses, and that's because, it has to do with like the actual anatomy and physiology of your body. It's not just something that you decide there. To touch on some pharmacology, you have psychomotor stimulants. These are drugs that increase the overall activity of the central nervous system. So this would be like caffeine, which you probably all need right now. Or if you're ADD like me, then you use amphetamines there. That helps with ADHD, things like that. Anticonvulsants, drugs that decrease the overall activity within the central nervous system. And you can use them to treat this seizure disorder. So Versed, benzodiazepines, or barbiturates are another way to do that. Opioids, we all know. Morphine, fentanyl are something that we give that affect the central nervous system. Endorphins and enkephalins and dynorphins, they're are in the opioid receptors we have endogenously in our body that those medicines work on. And then obviously anesthetic agents, propofol, ketamine, and all that good stuff are also central nervous system depressants. I guess ketamine. And then there's a special section they touch on here, and I know they quiz from, talking about anatomy, physiology, and pharmacology of nausea and vomiting. The area within the medulla has something called the chemoreceptor trigger zone, or CTZ. That when it's activated, it triggers people to throw up. So the CTZ has receptors for a number of neurotransmitters, including dopamine, acetylcholine, histamine, serotonin, and opioids. And that's how we treat intraoperatively, try to prevent people from throwing up, essentially. So Zofran, affects serotonin. Benadryl, histamine. Haldol we give is dopamine. Scopolamine would affect acetylcholine. Decadron we give, and we don't even know why it works. But it works, so we give it. But if they ever ask any questions, that's how it's all linked up. Those are receptors of the chemotaxis trigger zone. Those are the medicines that you'll learn that we give to treat it. There's also a receptor for cannabinoid, which they don't really mention in most books. But maybe one day we'll be using it intraoperatively to have a duty or something there to help them get their marinoid receptors there. Okay. Alright, so that's the end of that, CNS. Any questions? I would, as I said, that picture of the brain that says, the 4 parts of your brain, I would know all those, and then I would know your 2 different areas, the Wernicke's and Broca's area. So it's a good test question. The next section is the autonomic nervous system. So before I get into that, take a step back. So I always have to look at the big picture. So your nervous system is divided into your central nervous system, which we just covered. That's your brain and your spinal cord, and the peripheral nervous system. Peripheral nervous system is broken down even more to like your sensory, and then your motor, and then within the motor, it's broken down to somatic and autonomic. So that's what we're dealing with now is autonomic nervous system. Okay. You get bogged down in terminology here, but. So autonomic nervous system, essentially this is due to your sympathetic division, parasympathetic division. Sympathetic division, fight or flight. Okay, that's what we gotta think of. And then the verbiage for parasympathetics, that's nice, but it's rest or digest. So when looking at it, your sympathetic system works to prepare the body for stressful situations. So if a woolly, a saber-toothed tiger jumped in here, or someone with a gun, your sympathetic system would take over. Your parasympathetic counteracts the sympathetic system. So once you get all jazzed up, your heart rate's shooting up, you're sweating, your parasympathetic eventually takes over and kind of brings everything back to normal. Let's see, autonomic nervous system differs from the somatic nervous system in 2 different ways. Anatomically, let's see. So looking at it, the autonomic nervous system is a 2-motor neuron system compared to somatic. I have a picture that shows this better. And then it has to do with the neurotransmitters that each system uses. So this is a very messy picture that has to do with the sympathetic nervous system. Main thing to know about your sympathetic nervous system is that it originates from in your thoracic area, so T1 to T7. T1 to T12, and all the way goes down to L3. So lower half of your body is where the sympathetic signals arise from. Sometimes it's called the thoracolumbar division. And that it is the innervation of the adrenal medulla is unique. It's special. So your adrenal glands essentially is like the power horse of your sympathetic nervous system. And so there is a special thing, like it's innervated directly. So basically it's why the fight or flight response works so quickly, because there's a direct connection there. You'll see the rest of these, there's kind of like multiple connections like to get to the effector organ. Compared to the parasympathetic division. So all the connections go very close to the effector organ. So it takes longer for that transmission to get there since it's not as important. The major areas from here, I think it says it's the craniosacral division. So it's your cranial nerves. So you don't need to know the actual cranial nerves, but let's see, the preganglionic fibers from the parasympathetic division differ from the sympathetic division. So they travel uninterrupted to their effector organ. Yeah, I don't want to worry about that. It does make mention of the neurotransmitters used by each one here. So the main ones for the autonomic nervous system are acetylcholine and norepinephrine. And that has to do with where they're, I guess, delivered or offered up. I have a slide on that later, but there's two types of cholinergic receptors. Cholinergic receptors or the acetylcholine receptors. There's two different types. There's there's nicotinic and muscarinic. Nicotinic receptors are almost always excitatory. Muscarinic receptors can be either excitatory or inhibitory. I wouldn't get bogged down on that one there. This is just showing the different types of neurotransmitters that are used. So in the sympathetic nervous system, we're in the middle of blue. So you have your preganglionic neuron. So basically like a message sent from there, and then it uses acetylcholine to get to the next one. So most organs change it over from acetylcholine, and then it goes to the norepinephrine. Sweat glands are a little different. They stay with acetylcholine. And then your adrenal medulla is a little different as well. But sympathetic division is typically acetylcholine and norepinephrine, compared with your parasympathetic, which is acetylcholine the whole way. Within the sympathetic nervous system, so norepinephrine is released from the postganglionic nerves, just like we saw on the last slide, and those act on your adrenergic receptors. The adrenergic receptors are what the sympathetic nervous system stimulates. There's two major classes of adrenergic receptors. They're alpha and beta receptors, and they are further subdivided into alpha 1, alpha 2, beta 1, beta 2. This will become important when they talk about medicines that are used in pharmacology. In general, stimulation of alpha 1 receptors cause vasoconstriction. So that's where we use like neosynephrine, causes the vasoconstriction, increases the afterlife to tie everything in there. Alpha 2 receptors result in decreased release of norepinephrine from nerve terminals. That one's not that important. The beta receptor is important. Stimulation of beta 1 receptor causes increased heart rate and increased cardiac contractility. So that's like epinephrine. When we give epinephrine, is primarily beta 1 stimulation, whereas beta 2 stimulation causes dilation of blood vessels, dilation of bronchioles, which is good if you're doing a treatment for like a bronchospasm or something like that. It also causes your blood glucose to go up. Beta 1 and alpha 1 are usually the ones medicines we're using most often. So like neosynephrine is alpha 1, epinephrine or something like that is beta 1. So here's showing all the effects that sympathetic stimulation would have or parasympathetic. I would be familiar with this one as well, just in general. And you can think of this fight or flight, how you feel when you get nervous or excited, what happens to you. Your heart rate goes up, you're going to increase your heart respiration rate, when basically everything's going to the things that are important. So you're not worried about digesting stuff, so that decreases activity, and things like that. And then the opposite is parasympathetic. So you can just think of fight or flight, and you can think of the opposite as a parasympathetic stimulation. This is another picture showing effects. Look over those. And then common medications, and how they affect the autonomic nervous system. Most of these, again, you can probably think about, if you're giving morphine or Versed, you know what your patients look like after that. They're not really fight or flight, ready to like run from, danger. So they have a decreased effect on the sympathetic system. Most of the medicines we give decrease the sympathetic stimulation. So, peripheral nervous system. Remember we looked at that, the big chart there. These are nerves that carry information from the central nervous system from the periphery. So basically they're getting information to your central nervous system. So like, if I put my hand on something hot, something from my peripheral nervous system is going to send a message to my central nervous system to say, hey dude, move your hand, it hurts. If they're carrying information to the central nervous system, it's called afferent nerves. It's taking it away from my central nervous system. It's known as efferent nerves. An afferent nerve says, hey, it's hot. It goes into my head figures out, my central nervous system figures out what to do with it, and uses an efferent signal to say, hey, move your hand. Again, this has to do with signal transduction, axons, or we talked about those areas that send the signal, and if they're have a myelin sheath around it, it goes quicker. There's a big section on your study guide, and you guys kind of touched on it a little bit with positioning, things like that, with neuropathies. So neuropathies are usually classified according to distribution and its cause. I've never heard these terms, but maybe you'll need to know. Mononeuropathy is a neuropathy that only affects one nerve, and that's usually from compression. So you can see how that would be important in positioning. Mononeuritis multiplex is a simultaneous or sequential involvement of multiple nerves that occurs over time. So this is more medical conditions like diabetes, the neuropathy associated with diabetes, as well as polyneuropathy. Affects many cells throughout the body, or many nerve cells throughout the body, but not necessarily all neurons within a nerve are affected. The most common form of polyneuropathy is a distal symmetric form in which axons are affected in proportion to their length. The longest axon is being affected first. So again, that's common with diabetes as well. And this autonomic neuropathy is a form of polyneuropathy that affects autonomic nervous system. It's usually seen in people with long-standing diabetes and usually develops after polyneuropathy. I think I saw a question asking like the different types, so be aware of that. These are common causes and examples there. Mechanism of action for peripheral nerve blocks. Okay, so this kind of works as anatomy, physiology, and pharmacology. There should be the sections on here in your text. So this is talking about how local anesthetics work. It's basically, we block the sodium channel so that signal's never sent. So it prevents action potential from ever arising. When neuronal action potential is blocked, nerve function is lost. And it gets into details about dorsal and ventral horn. I wouldn't worry about that. And the pharmacology of it, I really wouldn't think you could go into details on it, but there it is for you. I guess I could probably talk a little bit about it. This just gets into how it works. You know, if we basically it's all pH dependent. Local anesthetics in the liquid soluble form. So this is like how local anesthetics work. If they're more liquid soluble, it's going to slow how quickly they work. But if you increase how liquid soluble, it predicts the potency of it and things like that. I would not bog yourself down to these at all. There's two different types of local anesthetics. Amino esters, so esters, we don't use very often anymore. And they're cleared by cholinesterases. And index would be like the only one that we use there. I could quite mess it up actually. So esters we don't use anymore. Cocaine's the only one that they sometimes use in ENT. Amides, those are the ones that you see all the time, lidocaine, bupivacaine, ropivacaine, things like that. They're cleared by the liver. And vulnerable populations include elderly, children, and those with cardiac or hepatic dysfunction. There's a little bit on local anesthetic toxicity. I would just know that basically like intravascular injection is the most common way that you'll ever see this. Actually putting a lot of it into the bloodstream. It affects your central nervous system first, and then your cardiac one, which is the big problem. Because if you have that, if you see local anesthetic toxicity, you get to the point where your heart's affected, and there's only one thing we can do. It's going to be something called lipid emulsion treatment. Something specialists may ask you to run it, because ACLS is not going to work unless you kind of give them this special kind of lipid. It's just the way it works. Neuromuscular anatomy physiology. So this is talking about your skeletal muscles, things like that. Skeletal muscles voluntarily controlled. It looks different than your smooth muscles and your cardiac muscles. It talks about just some terminology here. A sarcomere is the functional unit of a skeletal muscle. It's comprised of thin and thick filaments. The thick ones, or light and dark, I guess is another way to look at it. The light ones are actin, the dark ones are myosin. This is at the cellular level. How everything works is a sliding theory where your actin and your myosin contract and cause a power stroke. These are just a bunch of words that don't really affect too much here. This is talking about the neuromuscular junction. This kind of what I glossed over earlier, but it's basically like how your brain sends a message for your body to move. So your brain sends a message delivered via the action potentials or electrical activity, goes down your axon. It reaches the terminal portion of the presynaptic terminal, so that's like that dendrite I talked about. It releases acetylcholine, which is the synaptic cleft. That's just the area in between, I guess, where the signal's coming from and then where the signal's going after that. I don't think you need to know the details of this. Basically, the end result is it releasing a bunch of calcium. And that calcium is what causes your muscles to contract. If someone has hypocalcemia or doesn't have enough calcium in their bodies, you'll see symptoms. They'll just start spastically contracting, or their muscles will be hyperreactive. Just a signal there. Diseases that can affect this kind of function. This gets into detail about upper motor neuron disease. These are going to be MS, multiple sclerosis, or Parkinson's. If you have a spinal cord injury, it can affect your upper motor neurons. There's lower ones, which is Lou Gehrig's disease, this CMT disease, or Guillain-Barré's, or trauma is the other way there. A stroke would be something that affects your neuromuscular function. That's going to be above the level of your motor neurons actually in your brain. And let's see, there's two main diseases of neuromuscular junction. So this is actually the neuromuscular junction itself, where everything, like acetylcholine is released, and calcium is released. There's two major kinds: Lambert-Eaton disease syndrome and myasthenia gravis. You can see the actual, there's a little bit of difference about how that's affected. But I would just know that those are like diseases of the actual NJ. So how we actually manipulate this and cause muscle relaxation. We relax patients for basically two different reasons. Like either to optimize surgical conditions or to help us facilitate intubation. You can block it presynaptically, which is how Botox works. You kind of inject it into your head and it relaxes presynaptically. Or we do postsynaptic blocking drugs there. There's two different ones. You guys are all aware. So you have depolarizing agents, which is just acetylcholine, it's the only one we have. The way that works is it binds to the nicotinic receptors and kind of mimics it. So what your body naturally does, you have acetylcholine in your motor end plate, and it kind of binds onto the receptor and causes relaxation. But so acetylcholine mimics that and binds to it. And usually, like when I contract, acetylcholine binds on the receptor, it causes the muscle to move, and then it's quickly metabolized off the site, and so I can relax. And what happens in with acetylcholine is it binds like 5 to 7 minutes, and once you fire the signals, your body can't do it again. So even though we say relaxed, it's really just like your body's like unable to fire again. Okay, so acetylcholine works that way, just by mimicking acetylcholine. The other one we use is rocuronium or vecuronium or something like that. That doesn't work the same way. It's a non-depolarizer. So what it does is it binds to the site and prevents acetylcholine from joining onto it. Okay, it lasts a lot longer, as we all know. And so that's how that one works. It's a little different. So it's called competitive blocker.
Desiree Minster, 1901. Desiree Minster, 1901.
Non-depolarizing agents are the longer acting than the depolarizing agents due to their slower metabolism. You have to reverse them. Just throwing out some pharmacology that we covered. We use neostigmine, as well paired with like glycopyrrolate or atropine. The acetylcholinesterase, so like the neostigmine, prevents the metabolism of acetylcholine in the synaptic cleft, which increases the amount of acetylcholine in the synapse. and that's what's able to competitively, kick off the neurouranium off the receptor site. Unfortunately, it binds to all your acetylcholine receptors, including your muscarinic receptors. Your muscarinic receptors are tied to bad things like reduction in your heart rate and your GI cramping for nausea is another one. So we give glycopyrrolate, orobenol to kind of help mitigate that, I guess. Talks about monitoring of neuromuscular blockade. We all use the nerve stimulator to check your twitches, your sustained tetany, things like that. That's why we have those. That's all I have for you. Kind of messy, kind of all over the place. Of everything I covered today, I would highly recommend the heart and the lungs are going to be your main things. Anything else is going to be big picture. I had 90 slides, and they're asking 7 questions. So use your time wisely and where you spend it there. I think if you knew your heart and your lung pretty well, like the ones that I covered, and maybe a little bit of your central nervous system, you'd be fine. That's all I have. Any questions, comments, concerns?
Good job.
So you go home and get that beer. Yeah, I don't envy you guys. I mean, you guys can do it for sure, but it's a lot of